Okay, so up until this point in our journey through the cardiovascular pathophysiology, all we've done is talk about the heart. That's it. Heart failure, valve abnormalities, cardiovascular disease, coronary artery disease, but it's still related to the heart itself. Now we're going to talk about the rest of the vascular system, what can happen to your vessels, what happens with clotting, arterial disease, and so forth. So when we talk about hemodynamics, cardiovascular systems, you want to talk about the heart as just being the pump. So we can alter the pump function, and that'll alter our hemodynamics. We can also change the diameter of our resistance vessels. That's the arterioles. Remember, the arterioles have the very thick muscle layer that allows for constriction. So the arterioles have that. And we can also alter the venous blood that's pooled in our capacitance vessels. Remember, capacitance means to hold on to something. The AV node is a capacitance node. Remember, it holds on to that charge for a little bit before it fires off. Our veins are capacitance vessels. They can hold on to a lot of blood. Right now, you are all sitting. The blood is going to be pooling in your legs. I'm walking around, so I have my muscle pump working in my calves. That's pushing the blood up. So by me walking around, there's less blood in my venous side because I'm moving around. So those are the three things that we're going to alter to maintain cardiac output. We can alter how the heart beats. We can alter the vascular resistance through the arterioles. And we can alter how much blood is on the venous side. Okay, so how do we regulate the arterioles? Obviously, we need vasodilators that are produced in our tissues. We also have this autoregulation. What's autoregulation? You maintain that constant map. And what two organs have autoregulation? The kidneys and the brain. Those are the two areas that have autoregulation. And we have a variety of substances, or we're going to go through in this lecture, that alter the arteriolar resistance to either cause vasoconstriction or vasodilation to either raise or lower your pressure. We also have vasomotor nerves, and we get feedback from our carotid sinus, aortic arch, baroreceptors. Remember, baro means pressure. There was a question on your physio exam, and it said, which of the following deal with volume? Okay, and the answer was that juxtaglomerular apparatus. Remember, when they have reduction in blood volume, that apparatus can hold on and help resist the ischemia in the kidneys. However, all three of the other answers said the word baroreceptor in it. So if you're talking about baroreceptor, it's only monitoring pressure. Okay? So we have baroreceptors throughout our body. We have high pressure receptors and low pressure receptors. Basically telling our brain, do we have adequate pressure in our body? So we have regulatory mechanism. We have vasodilator metabolites. They include carbon dioxide, potassium, and adenosine. Okay, they help with blood flow. They're called vasodilation. Also, rise in temperature and a fall in pH also have a vasodilatory effect. What thing do people do that will cause your temperature to go up and your pH to drop? Exercise. And if you're exercising, you want good blood flow going to your muscles so that they can get good oxygen and get rid of the waste products. So when you're exercising, your body temp goes up, your pH drops because of the CO2 and the lactic acid production, so that helps with vasodilation. Autoregulation, we've already talked about with regards to that response to maintain blood pressure. And then obviously anything secreted by the endothelium itself, which we'll talk about as we go through. So the first one we're talking about is prostaglandins and thromboxanes. Okay, prostacyclin is produced by endothelial cells. So if you have damage to the vessel, you're going to release the prostacyclins. Thromboxane A2 is from the platelets, and they both come from that arachidonic acid. Okay? Thromboxane A2 causes platelet aggregation and vasoconstriction, whereas the prostacyclin will promote vasodilation. Remember, when you have an injury to the vessel, you want the vasoconstriction, the platelets, to happen at the site of the injury, but you want vasodilation on the sides opposite, the left and the right side of that damaged vessel, so the other parts don't have any issue with blood supply. You want to keep it open on both sides so you still have good blood coming in with all the healing factors, and you can still wash out all those waste products. So you need to have vasodilation on opposite sides of the injury, and at the injury, you want vasoconstriction. This balance can be shifted. We know that aspirin irreversibly binds, inhibits cyclooxygenase, the COX is what we call it. So when you give chronic administration of aspirin, we give it for people who have coronary artery disease because we know that the diameter of their vessel is already decreased because they already have obstruction. They have coronary artery disease. We don't want the platelets to plug up the entire diameter of the vessel because we know they have plaques. Okay, all that right there that I colored in red is the plaque. If that plaque cracks, now you have an open wound. Platelets are going to have to come back in to repair that damage. But we know that when platelets come, they're going to cause also, besides platelet aggregation, what also are platelets going to cause to the vessel at the site of the injury? Vasoconstriction. If you already have a reduced diameter size of your coronary arteries, why do you want them to constrict even more? Now you're going to cause a heart attack because now you're going to cause a full obstruction to flow because the platelets are there. And they cause obstruction and they cause an MI to happen. That's why we give aspirin for patients with heart disease. We don't want to have that plaque crack, platelets to come in, and now you've occluded the entire vessel. Nitric oxide, very potent vasodilator of our system. Okay? The biggest thing I want you to know from this is this last little bit right here, that nitric oxide is formed, but basically the end result is relaxation of vascular smooth muscle. That's the role of nitric oxide. That's why when people are coming in with chest pain and you think they're having a heart attack, if that heart attack is due to the vessel being constricted and occluded, if I give that patient nitroglycerin, which is the form that we can give nitric oxide in, what's going to happen to those vessels? They're going to dilate and get bigger. And if they dilate and get bigger, now you reduce that obstruction and blood can get through. That's why we give nitro for chest pain. And furthermore, for the most part, if you give a patient nitro, and you can give it 3 times every 5 minutes, if that does not relieve their chest pain, the likelihood of that being cardiac goes down because the nitric oxide is not helping. Does that make sense? So in that case, their chest pain could be musculoskeletal. It could be GI related. So one of the things you don't want to do when they come in with chest pain is you don't want to give them all at once nitro, Motrin for the pain relief if it's costochondritis, and let's say Protonix or Pepcid, which is a PPI to get rid of the acidity if it's gastric reflux. So you give all 3, and the patient says, oh, I feel better now. Well, which one was it? Which one caused their relief of symptoms? Was it the nitro? So yeah, maybe if the nitro does relieve their symptoms, they probably have a likelihood of it being coronary artery disease. But if it doesn't, then the Motrin, well, if they have costochondritis, just a little irritation of the cartilage, that will cause chest pain. But Motrin will take care of that. If it's acid reflux, burning sensation, they do this with they describe it. They do this, it's acid reflux. They feel a burning, it hurts right here, it's acid reflux. If they go like this or feel like a pressure on my chest, that's chest pain. If I say point to where it hurts, and they take their finger, it hurts right here when I breathe in, that's not chest pain. That's either pleuritic pain from coughing a lot, or they pull the muscle from coughing a lot. There's other reasons for that. But again, as you're going through these cardiac, yes, the most likelihood that you don't want to miss is cardiac disease. But as you go through your history, what you've done for that patient, how they present, is this really cardiac or is this something else? So nitric oxide, vasodilatory properties. Major regulator of blood flow. Nitric oxide is in a chronic fashion to keep the vascular system dilated. And we're going to see, when we get to atherosclerosis, you're going to see how this nitric oxide gets affected with the development of atherosclerosis, and where those places in the vessel where they have this damage, the nitric oxide doesn't work very well. So it's not working very well. And what's the purpose of nitric oxide? Dilation. So now I'm telling you that nitric oxide is not going to work. So what do you think these people are going to hop of atherosclerosis? High blood pressure. Because the nitric oxide, which is supposed to give you that dilatory property, is not there anymore. So the constricting property is going to win. And if you vasoconstrict, what happens to your pressure? It goes up. And if your pressure goes up, what happens to the size of the heart if it's untreated? Increase, you get hypertrophy. But what happens if you don't treat that now? What are you going to wind up with? Heart failure. So you see now why blood pressure is a really, really big thing to watch out for. And we'll get to the blood pressure a little later on. So the way they figured out is this reactive hyperemia and the role of nitric oxide. What they do for this test is they put a blood pressure cuff on your arm and they pump it up just above your systolic and they leave it clamped. So no blood gets into your arm, your forearm, and they leave it clamped for 5 minutes. Then they loosen it up and blood will start to flow again, and they put an ultrasound probe and they see your vessels. And what's going to happen is, because of this constriction for so long, if you have very good nitric oxide production and you're responsive to it, you're going to see your vessels distal to all that, they're going to dilate to allow extra blood flow to come into that area because it was ischemic for so long. And that's the role of nitric oxide. It's going to help dilate your vessels to promote this reactive hyperemia. When you've had this cut off for so long, we want to dilate it so that we can refill that tissue with blood that was lost due to the occlusion. You have a question? Okay. Okay, endothelins. We talked about endothelin a little bit when it came to heart failure, because endothelins are involved with matrix remodeling. Okay, it's going to change the shape of the heart when these endothelins come out. And they're found in vascular cells and muscle cells and macrophages and whatnot. But again, endothelins, the main result, it is a potent vasoconstrictor, whereas this is the opposite of nitric oxide. But we also know that endothelins, in response to heart failure, can cause some remodeling of that heart. The hypertrophy changes and so on and so forth. So our circulating hormones, our principal vasoconstrictors, your adrenergic hormones, the catecholamines. Okay, our principal vasodilators, our vasoactive intestinal peptide, anything that ends in kinin, the bradykinins, we'll talk about that in a second, and these natriuretic peptides that we're going to talk about in a little bit. So we have two potent kinins when it comes to vasodilators, bradykinin and lysyl bradykinin. Just no bradykinin and so forth. Produced by the tissues, kidneys, secreting glands, and we have some in the circulating blood. But what's the purpose of these kinins? Increase blood flow to actively secreting glands. Okay, so it helps the hormones work better. More blood flow to these glands means more product can be made and then eventually taken out to the body. So more blood flow to those areas helps with those hormone release. Natriuretic hormones. We've already talked about ANP when we talked about stretch of the vessels. Usually when ANP is referring to atrial, and the atria being stretched. We also found later on that when the ventricles are being stretched, like with volume overload, remember the ventricle volume is going up, so they're going to stretch more. When they stretch more in periods of what's called heart failure, volume overload, they can't pump the blood, the heart fills up too much, heart starts to stretch. When the ventricles stretch, they release beta natriuretic peptide. And this BNP is what we use as a marker of heart failure. Anyone coming into the ER, volume overloaded, their legs are both swollen and edematous, and they have a history of heart disease, everyone gets a BNP level on administration to the hospital. Because we want to see that this number go down with treatment. As we get the fluid off of your patients, the stretch of the ventricles should go down. And as the ventricular stretch goes down, less BNP should be released. So we want to know when they come in with heart failure, what's their emitting BNP? And before they get discharged, we want to follow that and make sure that's coming down. Yes?
How many times would you measure that?
On admission and probably a day, next day to see how the response to like Lasix and diuretics are, and then usually a day or two after that. Yes?
If the ventricles are overloading with fluid, won't that also back up into the atrium as well?
It will, correct.
So
But
it would release the ANP as well?
correct, but we use BNP more as a marker because more of the ventricles, where the atrial don't get stretched that much compared to the ventricles, they will stretch more. Yes?
Is there a baseline value you're looking for?
BNP, we want it less than 100 for compensated rest. So all of you right now should be less than 100. When people show up to the emergency room in heart failure, they may be like 300, 400, and you want to monitor that and make sure they're coming back down because that means the ventricles aren't being stretched and your treatment's working. Yes?
Is BNP elevated in athletes?
No, because it's not chronic.
Oh.
The increase, that's one of the benefits of exercise is the heart rate variability, where for that hour that you're doing something, your heart rate goes up, but then after 23 hours, it's back down to normal. And that's where that comes in. There is a third type, CNP. We don't really measure that too much, but just really know BNP is the big one. Remember, it's natriuresis, not diuresis. What's special about natriuresis? What are they doing with this one? What are they? Sodium. We're dumping sodium into the renal tubules to make urine. Remember, wherever sodium goes, water is going to go along with it, lowering your blood volume. Okay, so that's what it's trying to do. We can give other types of medicine if they're like in severe heart failure and they're hemodynamically compromised and they have to go to the ICU and their blood pressure is dropping. Then we can give them medicines that will help them stronger than, like we give them a form of BNP called Natricor. And it's a very, very potent BNP and it diureses you, but it's only used in the ICU. That's not a normal. Let me write that better. Natricor. Okay, neural control via our sympathetic vasomotor system. Okay, we know that when we discharge our catecholamine vasomotor neurons, it's going to cause arteriolar constriction, which is going to raise our blood pressure. When your sympathetic system is activated, it's also going to inhibit the vagus nerve, which is what? Parasympathetic. So the control system is blunted so that we can do our fight or flight response. Run away from a bear or whatever. We have discharge of the sympathetic nerves, increased BP and force and rate of cardiac contraction, which is going to end result increase stroke volume and therefore also increase your cardiac output. Okay, remember, fight or flight. We need the supply of blood to our muscles to do whatever activity we have to do. Run away, whatever. The control of this discharge occurs via feedback from our baroreceptors. So again, our pressure. If we're noticing that our pressure is too low, sympathetic will kick in to do what? If our pressure is low, sympathetic kicks in. What's it going to do? Vasoconstrict, which is going to do what to our blood pressure? Increase it. Because we're too low, our blood pressure is too low. If we have too high of blood pressure, now our pressure is too high, we have these high pressure baroreceptors. It's going to tell our sympathetic system, you're too strong, we need to blunt you down so that the parasympathetic can regain control and bring your pressure back down. Okay. The baroreceptors also cause endocrine changes. So again, if we have low pressure, low volume, renin gets released by the kidneys. What's renin going to do? What's the end result of renin? Reabsorption of sodium and secretion of potassium. Okay? And then vasopressin secretion by the hypothalamus. What is that going to do? And also what else? Vasoconstrict. Remember, vasopressin has two properties. Vasoconstriction, that's going to raise our blood pressure to bring it back up. And it causes reabsorption of what type of water? Solute-free water. So with vasopressin, ADH, it's just water by itself. Nothing else is in it, just plain water with vasopressin. So again, we're bringing water back into our system from the urine. If we're adding volume to the system, what happens to the pressure? Increases, and that solves our hypotension or during the low pressure systems. So let's move on to atherosclerosis. Affects large and medium-sized arteries in most every human, in most all societies in which cholesterol-rich foodstuffs are abundant and cheap, so American diet. So, okay, accelerated by, yes, genetic factors and environmental factors are playing a role. But what happens? We get localized fibrous thickening of the arterial wall with lipid-infiltrated plaques that eventually calcify. Okay, so we get a crack in the vessel. Smoking will do that. High blood pressure will cause micro tears. Uncontrolled diabetes. So all these risk factors, this is why they're called risk factors, because they increase your risk for micro tears in your arteries. And this process of repair is going to happen regardless. So the more risk factors that you have, the more likelihood that you'll have these tears, and they'll go untreated and cause more problems later on. So old plaques are prone to ulceration and rupture. And when it ruptures, it's going to trigger thrombus formation. And what's the first one to get there in the whole clotting cascade? Platelets. And what do platelets release? Thromboxane A2, which we don't want to happen right now because you're going to occlude the entire vessel. So we give them aspirin to prevent that from happening. Okay, so when you have this rupture, whatever vessel is occluded, you're going to have problems downstream. So when we talk about atherosclerosis right now in this section, the same process happens whether it's the coronary arteries, your cerebral arteries, your renal arteries, your femoral artery. They're all operate the same way. If your atherosclerosis develops in your cerebral arteries, what are you at risk of happening? Strokes. If it happens in your renal artery, you can have uncontrolled high blood pressure, which we'll get to in a little bit. So when we talk about atherosclerosis, we're talking about the process of how it invades the vessels. The effects only matter wherever the vessels are located that we're causing the problem with. Does that make sense? Okay. So if it happens in your vascular system in the legs, you're going to have arterial disease in your legs, and you have certain signs and symptoms when it comes to that. So pathogenesis. Initial event, obviously, LDLs have a major role in the subendothelial region. That's why we're so worried about LDL. It's the bad cholesterol. It's the one that will take the cholesterol and bring it to the tissues. HDL is your good cholesterol. It's the scavenger one. It's going to take cholesterol from the tissue and bring it back to the liver, where it can be repackaged in bile, or secreted out in the bile through the intestines, and we get rid of it. So we talk about shear stress. So remember, the bifurcations is where a lot of this stuff happens, that shear stress, the blood constantly being bombarding that bifurcation. And when you have high blood pressure, the pressure hitting that is even harder. So if you think about like erosion in rocks, where if you have like just drops of water every time hitting a rock over many, many, many years, you're going to see that wearing away. Think of that happening every time you have this bifurcation and you have high blood pressure. You're speeding up the erosion process. Those shear stresses cause micro tears in the vessel. LDLs get oxidized and are altered. There's different ways that can happen. LDLs also get recognized by scavenger receptors. This is the HDL. These are where those apolipoproteins come into play. The apolipoproteins, ApoB, ApoA, they're just like little hats that each cholesterol molecule wears so that the body knows this is a good cholesterol, this is a bad cholesterol. So these scavenger receptors, they're on macrophages, again, which stimulate inflammation and drive the atherogenesis. Do not confuse atherogenesis or atherosclerosis with arteriosclerosis. Atherosclerosis is the buildup of plaques and all that stuff. Arteriosclerosis is just a normal process of aging where the vessels lose their compliance, their recoil, their flexibility. It's like if you leave a garden hose out in the sun for too long, when you first buy it, it's very pliable, you can move it around. But if you leave it out all the time, it gets very hard and then it's going to crack when you bend it. That is arteriosclerosis. It's just a normal hardening of the arteries with age. Atherosclerosis is the pathological one, causing problems, foam cells, and all this other fun stuff. So these scavenger receptors uptake the oxidized LDL into the macrophages, and they form what's called foam cells. So it's a mixture of LDL macrophages trying to get into those little micro tears. So the foam cells, they're going to form the fatty streaks. Okay? Fatty streaks will appear in the aorta in the first decade of life, coronary artery disease in your second, and then finally in your third and fourth decades of life, it'll start affecting your cerebral arteries. So that's why keeping your cholesterol levels within normal ranges is important. You don't want to go too low in cholesterol because we need cholesterol in our body. Okay? Remember, what is cholesterol the precursor for? What hormones? What 3 hormones did we learn about? Or 4, really? Cortisol, aldosterone, and the androgens all need cholesterol to do it, to make those things. Your cell membranes need cholesterol to provide the rigidity. All of your myelin, that insulation is fat. That does it. Cholesterol, okay? There's stories where people have these really bad neurological problems. They put them on a really, really, really high-fat diet, and all that extra fat that they were eating went to help myelinate the nerves, and they were able to get some function back. Because again, it's cholesterol. We need cholesterol. You can't have it too low. Okay, so these oxidized LDLs have a number of problems and different effects, and the biggest one, inhibition of nitric oxide production. So this is a link between high cholesterol causing high blood pressure. Another big cause of high blood pressure we'll learn about is just obesity by itself. Obesity has become a risk factor for heart disease. It used to not be one. But now, independent by itself, obesity is a risk factor. Okay, so the vascular smooth muscle cells that are around where those foam cells, they get stimulated. And they move from the media, that middle layer, to the intima. Now they start to proliferate. Okay, put down collagen, other matrix molecules. But what's the important part of all this stuff? Leads to the bulk of that lesion. The size of it is going to increase now because all this crap that's getting lodged in there, the macrophages, all these other things. The intima smooth muscle coming up, or from the media into the intima, to re-endothelialize that plaque, to encapsulate it with endothelium. Okay? So we get lipid accumulation both inside and on the surface. And as the plaque matures, you finally get this fibrous cap that forms over them. This cap is what you want to keep as stable as possible. So based off of the history of how these caps form, how these caps are affected, what are some things that you as a future clinician want to talk to your patients about reducing what? What are some things that you want to reduce to prevent that fibrous cap from rupturing? What are some things you need to control for that patient? Blood pressure, very important, control blood pressure. If the blood pressure is in a controlled level, less risk for that plaque to crack because you're keeping the pressure controlled. What else? What other things cause problems with your vessels? Smoking. Tell them to stop smoking if they smoke. Cut out smoking to keep that plaque secure. The last thing is controlling cholesterol levels as well. It'll keep it secure. We want that plaque to be stable. We don't want it to crack. Remember, when it cracks, now you have a wound that needs to be repaired. Platelets are going to show up, and they're going to cause a lot of problems. Okay, so again, oxidized LDLs will inhibit nitric oxide production. Nitric oxide is our vasodilator. That's not going to work. It's going to cause more vasoconstriction. So, relation of dietary cholesterol and other lipids. I'm not going to go to great detail about this. You get this a lot more in cardio, but just remember that we have different forms of these LDLs. We have very low density lipoproteins. That's the first thing that usually happens. As they start to enter circulation, they lose some of their fat content. And as they lose their fat content, they go from VLDLs to these IDLs and LDLs. It's basically just a way that they lose triglycerides. They get rid of them, they put the trigs into the tissues, and they become lower dense lipoproteins. HDLs, again, those are the good ones, take cholesterol from the peripheral and they bring it back to the liver. So having a high HDL is very, very good. Ideally, you want HDL above 40, and the higher it is, the better. The only way to get HDLs up is exercise. Yes?
Like, why do some people have like high HDL, but it doesn't matter, like their LDL is still high? Like, how do you have both high?
Familial high cholesterol. You're going against genetics. So that's HDLs. Okay, so clinical manifestations, again, yes?
So you said the only way to rise it is exercise. Why do people say fish oil?
It's to control the other ones.
Oh,
So that's more for the LDLs and trigs. What?
won't do anything.
So the atherosclerosis depends on where it's developing is where you'll get symptoms. Okay, usually asymptomatic until a complication develops. What complication in men will cause them to go to the doctor to get checked out? Erectile dysfunction, which is a form of atherosclerosis. Okay, that's when they'll come and see you. Okay, if the atherosclerosis is in the coronary arteries, you get chest pain. If it's in cerebral circulation, you can cause thrombotic strokes. Abdominal aorta, you guys all measure the aorta, right? You put your thumbs there, measure it perfectly, right? You know exactly what you're feeling for. You're looking for dilated abdominal aneurysm if the width is wider than that. Again, atherosclerosis of the abdominal aorta can cause that. If it's in the renal vessels, it causes renovascular hypertension. So remember we talked about the RAS system. If you have renal artery stenosis due to atherosclerosis, and let's say it's only on the right side. The left renal artery is okay, but you got some atherosclerotic plaques developing in the right renal artery. Is that right kidney going to get adequate blood supply? No. What is that kidney going to think? Low blood pressure, because that right kidney isn't getting enough blood. So that right kidney is going to think that there's low pressure in the entire system. But is there low pressure in the system? No, you're occluding that renal vessel. So what is that kidney going to release? Renin. And what's the end goal of renin? Increase your blood pressure. So you're going to have this patient come in with high blood pressure, and you're going to give them medication to treat their blood pressure. Do you think that medication is going to work? No, it's not. One of the clues, and we'll get to this when we get to hypertension, but we're talking about now with regards to atherosclerosis. If you have a patient who you're giving blood pressure medications to and they're not lowering their blood pressure, there is another underlying cause. And one of the major ones is renal artery stenosis. Very easy fix. You put a stent in that stenosis, you open that vessel back up again, and now the kidney gets adequate perfusion, renin drops, and your blood pressure drops. Do you see how you can trick the kidney into thinking that you have low pressure, and that will cause high blood pressure? If it happens in the legs, it causes intermittent claudication. So as they go to walk, when they get to certain intensities, their calves start to hurt. Why are they hurting? Because the demand of oxygen went up, but you can't match the supply because you have atherosclerotic plaques in your peripheral vessels. So as you start walking, the demand goes up, the supply can't reach it, so you get pain and you get cramping. Once you stop, the intermittent claudication goes away. However, one of the things to keep in mind are some patients are called, we call them vasculopaths, which means if they have arterial damage in their legs when they walk, it's safe to assume they have that everywhere else. So if they come in to see you and they have intermittent claudication and like, yeah, I walk to my car and my calves start hurting, I rest and I'm okay, you better stress test them. Make sure their heart's doing okay. Because if they have issues in their legs, they probably have it in the coronary vessels. You can't really check the cerebral ones, but the heart ones you can. So if they have symptoms of some vascular abnormality due to atherosclerosis, it's safe to assume they have it everywhere. Yes?
Is there like a usual spot in the body that it starts and then like goes everywhere else?
So remember, the aorta is the first one, and then the streaks happen, in the coronary arteries around 20 years old, and third and fourth decades in the cerebral arteries. But if they have underlying diseases, they smoke, they have uncontrolled sugars, these are going to lead to these things to happen more rapidly. That's why lifestyle modification is so important. Look at their modifiable risk factors. Eating, cut out the sugars, exercise, the diet, smoking, drinking, alcohol, cut that back. These are lifestyle modifications that will help improve those things that are going on. If the circulation of the limb is severely compromised, then you can get gangrene. We learned about gangrene in the first lecture. Remember, lack of blood supply to an area? If you have severe ischemia in your toes, they're not going to be perfused, they're going to die off. Okay? So again, depends on where the atherosclerotic plaques are developing is where you will have symptoms from it. Risk factors for atherosclerosis, estrogen. Okay, estrogen helps protect you from heart disease, which is why if you look at the risk factors, if you look at if you have a family history of heart disease, if my father had a heart attack before 55, that is a significant risk factor. But for the females, for the mother, it's 65. Why? They have estrogen, and they hit menopause around 50s, late 50s, they hit menopause, now they don't have the estrogen. So the cardioprotective part goes away. That's why hormone replacement therapy, estrogen, helps protect the heart in females. Okay? That's pretty much all I talked about. Homocysteine. Homocysteine is a marker of inflammation as well. So if you have elevated homocysteine, it's been shown to accelerate atherosclerosis. Okay? Homocysteine is metabolized by vitamin B6, B12. So if you've ever heard of genetic testing, MTHFR, this is what they're looking at, homocysteine. Because B6 is folate, I think, or B12. I think B6 is folate. So anyway, people have this problem. It's methylation of folate. I can't remember what they are. But it's looking at this homocysteine irregularity. So if you have this gene, taking like folic acid every day will help because it's going to metabolize a homocysteine, which could lead to atherosclerosis. Smoking, okay? Pack of cigarettes a day have a 70% increase in death rate from ischemic heart disease just by smoking.
But just men
Men, because remember the women,
have estrogen.
yeah, that helps. Not to say you should smoke because you have estrogen. It's still going to cause problems, but not as severe. Again, the effects of smoking: endothelial damage by carbon monoxide induced hypoxia. Okay. Did I ever tell you about why people see ghosts or think they see ghosts? These old houses, because they have carbon monoxide leaks. And when people walk around in them, they get lightheaded and they start thinking, oh, the noise, and they think it's carbon monoxide, for the most part. Otherwise, it's like, oh, if I told you that exam room 6 is haunted, before you went in there, and you went in there and you hear a noise, you're going to think, oh my God, there's a ghost. But that's giving it to you beforehand. Lowering cholesterol and trigs, increasing HDL, slows and in some cases reverses the atherosclerotic process. So again, tight cholesterol management. Sometimes it can be due to dietary restrictions if they are disciplined and watch their food intake. So like I said before, when the first time you're diagnosing someone with high cholesterol levels, you can give them the option and say, I'll give you 3 months, work on your diet, work on your exercise, let's see how your cholesterol levels improve. If after 3 months they don't improve, then we have to go about giving you a medicine for this. But give the patient the opportunity, talk to them, give them correct patient education about what healthy eating looks like, exercise levels, and all that stuff. And obviously, hypertension is a cause, risk factor for atherosclerotic development. Again, those increased shear stresses causing endothelial damage. Diabetics is a risk factor. They cause microvascular and macrovascular complications, so diabetes will affect the small and the large ones. And nephrotic syndrome and hypothyroid can also accelerate the atherosclerotic development. So let's take a break and we'll talk about hypertension. So come back at 11. Okay, guys, let's get started. Okay, so we're moving along. We dealt with atherosclerosis. Now let's talk about hypertension by itself. When you talk about hypertension, you have to classify it. Essential hypertension is really like an unknown cause. Just people get high blood pressure. There's no underlying cause for that patient's high blood pressure. That's essential hypertension. There's also secondary hypertension, and that means the cause is known. There's your renal hypertension. We talk about renal artery stenosis. Cushing's syndrome. Anyone know what Cushing's syndrome is? What? Is it cortisol? Yes, cortisol. Look at the other one, Conn syndrome, aldosterone. But yes, cortisol is Cushing's. Pheochromocytoma, we'll get to that in a minute. And then obviously this estrogen pill hypertension as we talk. You don't need to know these guidelines for my class, but you will have to know it for cardiac when you start that up in a couple weeks. Just know that normal is 120/80, and pre-hypertension, anything below 140/90. And then after that is just hypertension. So 140/90 is the cutoff. There are grades after that. Don't worry about it for now. You'll get it more with Dr. Ovalle when it comes to that. Pathogenesis. What causes high blood pressure? Easiest one, increased peripheral vascular resistance. Makes sense? You tighten your vessels, constriction goes up, pressure goes up. Prolonged increase in cardiac output. Okay, high volume coming out, blood volume, high blood viscosity. Blood becomes thicker, harder to move through the system, resistance goes up. We didn't talk about viscosity a lot when it came to resistance. That equation that we did like lecture 1 of cardio. Remember the length of the tube, radius, and the viscosity of the blood was the third one. So if you have really, really, really severe dehydration, remember we're removing all the water out of your blood, so all the solutes have more of a role, blood becomes more viscous. The other way, polycythemia vera, which is a condition where you have way too much production of all your blood cells. You can have way too much red blood cells, too much platelets, too much white blood cells. That can make your blood viscous as well. Presentation, non-specific. They're not really going to have any complaints. Again, often discovered during routine screening. A few years ago, many years ago, they did a study trying to catch people with high blood pressure. And what they did was they targeted the local hair salons and barbershops. Because what are you doing for those 15 minutes while they're cutting your hair? Nothing. Then after the 15 minutes, they put the automated blood pressure cuff on you, and they see what your blood pressure is. Because to do a true blood pressure, you have to be sitting for 5 minutes. You can't just walk in, sit down, put a cuff on you, and get it. It's going to be high. Because you're moving, your blood pressure is going to be a little bit elevated. You have to be resting for 5 minutes. So they did a study, and they were catching people with high blood pressure just after 15, 20 minutes of sitting in the chair. They did the blood pressure readings. Hypertensive retinopathy. Okay, you all will see this on your awesome eye exams, right? Now, the reason why I know I joke about that is because when I was in PA school, same thing. My partner will look in my eyes and say all this other nonsense. And I had blurry vision. I went to the eye doctor, and I had retinal vein occlusion, and I had all the pizza wheel and all the hemorrhages and all that stuff in my eye. I had a picture of it. I'm like, look, you know what you're doing. It's hard to do an eye exam, I get it, but hypertensive retinopathy is one thing they'll have. LVH, cardiac enlargement, bruits are signs of hypertension. So this is a really good review slide that kind of goes over why high blood pressure is so bad for us, uncontrolled. Remember, everything is uncontrolled. So hypertension does two things. Increases the afterload. That's going to affect the heart, the pump, and it affects the vessels, causing arterial damage. So those are the two things that high blood pressure causes. Now, untreated for many years, again, doesn't happen overnight. This is going on for years. This increased afterload is going to cause problems on the heart. Systolic dysfunction, LVH, increased myocardial oxygen demand. Why is the demand for oxygen going to go up? Hypertrophy is going on. We're having thicker muscles. They require more oxygen. The demand goes up. The harder the heart has to work to generate that pressure, increases the demand for oxygen. So LVH will lead to diastolic dysfunction. So high blood pressure will lead to systolic dysfunction and diastolic dysfunction. Those two things are going to lead to heart failure. So this is how high blood pressure leads to heart failure. Now let's go on the other side. Arterial damage causes two things. It starts the atherosclerotic cascade, because now we're causing tears in the vessel, that all those foam cells, LDL oxidation, macrophages all get stuck inside. And it also weakens the vessels as well, because you're making these little holes in it, these little tears. With the increased atherosclerosis, again, depending on where it develops, those are the symptoms you'll get. If it's in the coronary vessels, you get myocardial supply goes down. The pipe got smaller, less blood can get through. If it's in the cerebral arteries, you get a stroke. If it's in the aorta, you can get an aneurysm or a dissection. Aneurysm, the vessel bulges and gets wider. Dissection, because of this repeated, let's go to the aorta. Let's say this blood is high blood pressure and this blood is always beating that one part of the aorta. What's going to happen is it's going to drill a hole in that, and now you have a little hole, and that hole gets wider as the blood starts to fill in. That's dissection. You're causing another route of blood to travel. This makes the vessel very weak, and those are the ones that will pop and cause bleeding everywhere. These weakened vessel walls also obviously will affect the aorta, causing the aneurysm or dissection. But again, you weaken the vessel walls, cerebral vessels, it can cause a hemorrhagic stroke. A hemorrhagic stroke is where the vessel bursts and blood is just oozing out from the hemorrhage. If you're losing blood to the hemorrhage, no blood's going to the brain tissue, that's a hemorrhagic stroke. An ischemic stroke is because there's an occlusion in the vessel and no blood can get past it. That's an ischemic stroke. That's due to atherosclerosis. That's why it says ischemic stroke for that side. But if the vessel is very weak, it can burst, and that causes a hemorrhagic stroke. If it happens in the renal vessels, it can cause nephrosclerosis, renal failure, and ophthalmic vessels, retinopathy. You get the little bursts. Those little capillaries and vessels in the artery burst and they pop because of the increased pressure. They don't like it. And when you combine increased demand for oxygen, decreased supply of the blood, it leads to ischemia and infarction. This is why blood pressure is so bad. This is why it's called the silent killer, because no one knows they're having these problems until they are in this range, right? That's when they start getting symptoms. Males with erectile dysfunction, oh, I better go see a doctor. Well, those are the ones that show up at Friday at 4, and they're gonna have all these problems, and you'll be there until 6 o'clock. So this is a great summary slide to look over for this section as far as hypertension. So again, if untreated hypertension, the atherosclerosis accelerates, ischemic heart disease, angina, and MI. Uncontrolled blood pressure alone will decrease your life expectancy 10 to 20 years. That's why it's called the silent killer. And obviously, we've already gone through those complications in that graph before. So management, you're going to get a lot more in CMS and pharm. Beta blocking drugs, inhibiting the renin-angiotensin system, those are your ACEs and your ARBs. Calcium channel blockers and diuretics, all those things are reducing the stress on the heart so that your blood pressure can drop. It is not curative. You have to tell your patients this is probably going to be a lifelong medicine you're going to be on with high blood pressure. Unless they're like really overweight and they lose all the weight and the pressure comes down, lifestyle modifications, they exercise and so forth. If the cause of the hypertension can be identified, then you can cure it because now you know what the underlying cause is. So one of these underlying causes of high blood pressure is a coarctation of the aorta. Obviously, this is congenital. Okay, so there's a narrowing of the aorta. What is that going to do to your afterload if you narrow the aorta? Increased it. So therefore, your pressure goes up because you're pushing against a coarctated aorta. You fix the coarctation, the blood pressure goes away. Salt sensitivity. 30% of white population with normal renal function, normal blood pressure are salt sensitive compared with 55% of African Americans with essential hypertension. Okay, so salt sensitive, which means when you add salt to the food, the pressure goes up even more. Renal abnormalities, here's your renal artery constriction, stenosis, whatever you want to call it. But again, remember, renal artery constriction leads to activation of your RAS, which is going to raise your blood pressure also. Here's your renin-angiotensin abnormalities. If you get an increase in angiotensinogen secreted from the liver, that can start a cascade. What is angiotensinogen? What happens with that? Where does that fall in with the whole renin cascade? Renin cleaves angiotensinogen to angiotensin. So renin-angiotensinogen is the precursor. And when renin comes out, it's going to cleave it and start the whole cascade. This is stimulated by estrogens. So any oral contraceptive with large amounts of estrogen can cause high blood pressure in women. Okay, this is called pill hypertension. and it's due to estrogen. Now, we gave estrogen because it's cardioprotective as far as the atherosclerosis development, but sometimes estrogen can cause high blood pressure because it activates the renin system. Adrenal disorders, this is what I was thinking about before. This is Conn syndrome. That is hyperaldosteronism. So if we're secreting too much aldosterone, what's that going to do to your blood pressure? Increase it. So there are tumors that just secrete aldosterone, and there's no negative feedback because it's a tumor. They have no receptors to shut off production, and they just keep pumping it out, pumping it out, pumping it out. Glucocorticoid excess, that's your Cushing's disease. And then excess secretion of catecholamines, this is your pheochromocytoma. This is a tumor in the adrenal medulla. And what comes out of the adrenal medulla? Epi and norepi. So you have a tumor in there, and what happens is some people, when you bend over, you can compress that tumor, and when that tumor gets compressed, it's going to squirt out a ton of catecholamines. So your blood pressure skyrockets when that happens. Blood pressures with pheochromocytoma can get to like 250, almost 300 systolic. So obviously, what are they at risk of happening when the blood pressure goes that high? Stroking out, okay? That's a big risk with pheos. Obesity, again, talk about the link between obesity and hypertension. Obesity also causes insulin resistance. So that goes up with hypertension and obesity. And research now is thinking that the insulin resistance from the beginning is starting the entire cascade, as well as obviously diabetes and high cholesterol. I put this in here for you guys just to keep as a reference. It's a great cheat sheet for cardiac drugs. So just save it. I'm not going to ask any drugs on your exams or anything, but again, for cardio, for pharm, this picture is really good. Yes?
For someone who is overweight, would you call that secondary hypertension, or would it have to be essential?
In classification of it, we only say secondary when there's no underlying cause. If they got rid of the weight, there's no guarantee the blood pressure will come down either. It'll help, obviously, and help other factors as well.
Okay.
But like people who are like morbidly obese, if you ever watch like 600 Pound Life, the people who do take care of themselves afterwards, they're off all their medications because the weight came off. Just think about if you ever like walk, just put a 50-pound pack on you and walk around, you see how much pressure that is on your system and you take it off and you feel so much better. That's what obesity is like. You just take all that weight off, the pressure comes off. Okay, moving on to shock now. Shock there's 4 different types we're going to talk about, but we're going to talk about in what causes them. As far as the treatments and all that stuff, you're going to get with Dr. Ovalle later on. So shock is defined as tissues are not perfused adequately due to relative or inadequate cardiac output. There's not enough output from the heart to perfuse our tissues and our organs, and it's called shock. There are 4 different types. Hypovolemic, think of a hemorrhage. You're losing blood like crazy. That's hypovolemic shock. There's not enough volume in the system. There's distributive shock. This is known as vasogenic or low resistance, cardiogenic, and then finally obstructive. So the pathophysiology is pretty much the same across all 4 of them. We'll go through little details of what makes them different in a minute. So we're not perfusing our tissues adequately enough, not enough oxygen. We have to shift to anaerobic metabolism. When we shift to anaerobic metabolism, we produce lots of lactic acid. This lactic acidosis suppresses the function of the myocardium, so we have less of a response to our catecholamines. Okay, we get generalized vasoconstriction, shifts the blood to the vessels of the heart and brain. Remember, the core is what matters the most. The periphery doesn't. We got to keep the blood in the core, feeding your heart, liver, brain, kidneys, and so forth. So they may get increased heart rate, and that's from increased myocardial metabolism. You get cool, pale, clammy skin, and that's from vasoconstriction of your vessels in the periphery. Vasoconstriction also leads to decreased renal perfusion, low GFR, so they get a pre-renal azotemia. This is all happening before the kidneys. All these changes, are nothing, the kidney has nothing to do with this. This is all whatever's coming into the kidney. Our carotid and aortic baroreceptors are stimulated, but these can fail when BP goes less than 70 millimeters of mercury, those low pressure baroreceptors. Circulating levels of our vasopressor hormones increase. What do vasopressor hormones do? Vasoconstrict. Okay, with distributive or with shock in general, it usually causes a lot of vasodilation as well. So we're trying to reduce that vasodilation with the vasopressors. And again, angiotensin 2 is here, epinephrine, norepi, and your vasopressin. And we know what those effects do. So the first one we're talking about is hypovolemic shock. Inadequate volume to fill the system up. Remember, normally our cardiovascular system is a closed system, so whatever's in it is going to stay inside the cardiovascular system. If you have a cut and your femoral artery is bleeding now, you're going to lose blood out of that system. The volume is going to drop. So some etiologies, hemorrhage is here, trauma, surgery cause a lot of blood loss. Burns, they have a lot of fluid loss with these full thickness burns, and the more area of the skin has been damaged, the greater the risk of fluid loss is. So you have to watch out for hypovolemic shock with burn patients. So we have a decreased intravascular volume, so our cardiac output drops. We have normal responses that our body is going to do to increase our blood pressure again. Because remember, we need that blood volume up. So while we're going through this, just remember, we have an open wound that's losing blood, and that's why our blood volume has dropped. Start from there, and as we go through it, you're going to see how this cycle is very, very bad. So we have a reduction in cardiac output. We need to raise our blood volume again. These are the ways we're going to raise our blood volume. Remember, shift of interstitial fluid. Go back to lecture 1 of physio. We talked about fluid compartments within the intracellular fluid and the extracellular fluid. Remember, there's a lot of fluid in the intracellular space that is there as a reservoir. So in case we have a hemorrhage, we can pull water out of our tissues to put into the vessels to raise our blood volume. And that's the goal, raising blood volume. Now, when we have low cardiac output, we also have catecholamine released. Because we're low cardiac output, we need to increase our tone of our vessels, increase our cardiac output, sympathetic system has to activate. When that happens, it increases the heart rate contractility and increases our systemic vascular resistance. What's the goal of all of this? To raise our blood volume up, right? But in a closed system, this will work just fine. We're dehydrated, severe dehydration. These processes kick in to raise our blood volume again. However, the problem is, as we increase our cardiac output, we're going to cause more volume loss because we have an open wound. So every time the heart beats, you're going to lose blood out of that wound, if it's a femoral artery or whatever. So yeah, we want this to happen. The problem is we have an open wound. So blood is going to continuously being lost. And the harder that the heart works, increasing cardiac output, makes the volume loss even faster. Because now the heart's pumping even more, you're going to lose more blood that way. Which leads to decreased cardiac output, leads to decreased tissue perfusion, and eventually impaired cellular metabolism. Because there's an open wound somewhere, and again, what's the first thing everyone learns whenever you have an open wound that's bleeding profusely? Pressure. You're trying to seal up that wound to repair itself, but also preventing more blood loss. That's why they say if you ever get stabbed with something, leave it in there before you don't take it out and then go to the hospital. The minute you take it out, you're going to bleed everywhere. But while that knife is still in you, leave it there, go to the hospital, and then they can treat you from there. That's hypovolemic shock. Distributive shock is the next one. All previous mechanisms are there, but in distributive shock, there's vasodilation, and this is the key one. Distributive shock causes a vasodilation. So they're not going to have that cool, pale, clammy skin. They're going to be warm. Because in distributive shock, they have profound vasodilation. And if you look at the conditions here, it'll make sense. First one, anaphylactic shock will cause a distributive shock. Large amounts of histamine, marked vasodilation, blood pressure falls. This is vascular collapse. There's no more tonicity, there's no more tone keeping these vessels constricted. They're just wide open. There's not enough volume there to perfuse those wide vessels, and you go into shock because there's no volume there to do all that. Neurogenic shock. You'll see this with people with head and spine injuries. Someone come in, they fell off a ladder, they hit their head. Watch out for distributive shock. That is a common mechanism. This is why when you're doing your history, you want to know what's the mechanism of the injury. How did they get hurt? What were you doing when you hurt yourself? That really, really matters a lot when you're talking about treatments. They get sudden loss of autonomic activity, vasodilation, pooling of blood in the veins. So there's no cardiac output, and they pass out, syncope. They also postural syncope, causes syncope when standing. This is a neurocardiogenic cause. There's no tone there. You almost induce a distributive shock. This is where people, they pass out from like common faint and stuff like that. Some of them, it's called neurocardiogenic shock or syncope. When they stand up too fast, blood pressure drops too much and they pass out. And the last one is just your septic shock. Very, very common cause of ICU admissions. They come in from sepsis, and sepsis will cause a distributive shock. Cardiogenic shock. In this case, the heart is just not working. There's no pump. Massive MI. Left main disease, where the whole territory left ventricle is gone. There's no LAD perfusion. There's no circumflex perfusion. Okay? These are massive amounts of extensive LV infarct. The pump is not working, so there's no cardiac output. So you get this immediate pump failure, what leads to obviously cardiac output decreases, tissue perfusion, lactic acid buildup again. And remember, lactic acid will suppress myocardium contractility. So this is cardiogenic shock. Again, the heart itself just is not pumping, so that causes a shock to develop. The last one is obstructive shock. This is obviously due to an obstruction in the vessels. First one, right-sided failure, massive pulmonary embolism, or pulmonary hypertension. These are obstructions to flow. Okay, the right ventricle can't overcome large pressures in lung volumes. Okay, we get pulmonary hypertension, massive pulmonary embolism. Okay, what side of the circulation does a pulmonary embolism come from? Right side, the body, right? Comes from the veins. You have a clot in your leg, it breaks off, goes up your femoral vein, IVC, right atrium, right ventricle, lungs, and that's where it gets lodged. So a DVT is a risk for a pulmonary embolism. It's the only side it's on. Mechanical may look like hypovolemic shock due to decreased preload versus an actual pump failure. So we're having with a obstructive shock, there is inadequate filling of the ventricles, and this could be due to a tension pneumothorax, your pericardial tamponade, constrictive pericarditis. We learned about these restrictive diseases, the constrictive pericarditis. What do those things not allow the heart to do? Expand, so they can't fill. These are filling problems. And if we're having a problem with filling, we know that the preload is going to be the one that's going to have an influence on this. Okay. Moving on to thrombosis. Okay. We have arterial and we have venous thrombi that can occur in both. So a thrombus is the stationary clot that's formed. An emboli is something that breaks off of that thrombus and is now floating to somewhere else. That is an emboli. Thrombus is fixed. Emboli will start moving. It adheres to vascular epithelium and again result in ischemia from decreased distal flow for the blood. There's nothing that you can't get through, so anything distal to that occlusion is going to have problems. Vessels commonly involve, obviously, coronary, cerebral, mesenteric, and your renal arteries. Risk factors, immobilization. Someone comes in with a DVT in their leg, a deep vein thrombosis. One of the questions you want to ask, have you done any recent travel? If you are on a plane from here to the other side of the world and it's a 15-hour flight and you're just sitting there the entire time and not moving, that will lead you to possible getting a thrombus. That's why we ask about travel. If you're in a car for 15 hours, you don't go anywhere, that can develop a clot. That's why we ask you to keep moving and keep doing things so that blood doesn't pool in your venous system. Metabolic syndrome, obesity, hypertension, insulin issues, dyslipidemia, advanced age, tobacco. Remember, smoking will cause problems in the vessels, which can develop clots. Any prior thrombosis, so if you're young and you start developing clots, there may be some genetic things there, factor V Leiden, Christmas disease, all those other things that you'll learn about in hematology. And obviously cancer can also cause risk factors as well. This is Virchow's triad. You got to know this one. These are the 3 risk factors for developing a thrombus. 1, endothelial damage. There has to be some sort of damage to the wall. We know hypertension does that, smoking does that, diabetes does that, and so forth. There has to be alterations in blood flow, either turbulent or slowing of the blood. Remember, blood that doesn't move and it just sits there for a while can clot. So alteration in blood flow. And the last one is coagulability of the blood. How coagulable is the blood? If you're in a hypercoagulable state, you'll be throwing clots. If you're hypocoagulable, you're not having clots because you're altering those proteins. So once a thrombus starts to form, there's a couple of things that can happen to it. It can lyse, just break up and go away. It can propagate, get bigger and bigger and accumulate more material as it passes through, getting bigger as a thrombus. It can organize, which means it's getting firmer. It can canalize, which means if this is your artery, and let's say you have a thrombus right here, it'll canalize, meaning you'll have a hole that goes right through it, that you make a canal, and blood can get through that thrombus now. Okay, new lumen from within the thrombus. It just makes a whole new tube, and blood can get through it, yes?
Does that like form a whole other pathway?
No, but remember the thrombus is only a little piece. It's not the whole length of the vessel. Once you get past the thrombus, you're okay. Or it can embolize, where part of it gets dislodged and it breaks off and it travels throughout the body. Remember, however big that emboli is, once it gets to a vessel that's smaller than it, then it gets lodged and causes occlusion. So an arterial embolus may begun as a thromboembolus. So it was a thrombus first, got dislodged, and now it's traveling throughout the body. It's an embolus. And wherever it goes, it will cause an obstruction. If it happens in the brain, it's a stroke. If it happens in the lungs, it's a PE, and so on and so forth. So that's arterial. Deep vein thrombosis, again, most likely in the lower extremities in the pelvis when they get DVTs. But again, Virchow's triad. Venous stasis, blood's not moving anywhere. Post-op immobilization, long-term bed rest. If you're admitting a patient to the ICU and you know they're going to be in the ICU for a while and they can't move, what are the things that we put on their legs? SCDs, sequential compression devices. What are they doing? They're mimicking the muscle pump. They go on your calves and every minute or so they squeeze and it pushes the blood, keeps it moving so it doesn't stay stagnant in the venous system. Prolonged bed rest and all of that. Vessel wall injury or inflammation, any history of trauma or surgery will do it. And that hypercoagulability state, oral contraceptives, it makes you in a hypercoagulable state, and obviously cancer is there as well. So make sure you understand the three: venous stasis, venous wall injury, and a hypercoagulable state. That's Virchow's triad. So you can read that one on your own. Okay, deep vein thrombosis. Edema is only to the affected extremity. So if you look at this picture, you can see that left leg is extremely swollen compared to the right. Whenever you see unilateral swelling like this, immediately DVT, not heart failure. Heart failure edema will be both legs, will be swollen and not as red as that and inflamed. So heart failure will have bilateral edema, but a DVT probably most likely is going to show up as unilateral swelling because that one leg is affected by that clot. Heat and tenderness to the site. They may or may not have that Homan sign. You guys know what Homan sign? I think you guys had to do that? No? Okay, you will do it eventually. But basically, you squeeze the calf. It's not very specific for anything, but they still teach it. You squeeze the calf, and if they cause any pain, they may have a clot there. But that's why it may or may not be positive. You may or may not find anything. So that's thrombus formation. Now the last little section we're going to talk about is peripheral vascular disease. Yes?
If you want to play, what would you do?
Just get up and walk every hour. Just walk up and down the aisle for a little bit and go sit down. Just get up and walk. That's all you got to do. But if you also know that you're at risk, then you can wear those support stockings. Those TED hoses, you can wear those. They'll help too. Okay, peripheral vascular disease. If you want to see this, go to Disney and just sit there and watch everyone. You will see all forms of peripheral vascular disease just observing people. I say Disney because it's highly populated, so you can see a lot of people. So when it comes to vascular disease, you have to know, is this an arterial damage or is this venous insufficiency? Where is the problem? So peripheral arterial disease. It's arterial, so large peripheral arteries are going to be affected, mainly of the legs. Etiology, most likely atherosclerosis. We talked about intermittent claudication before. This is where it's going to come into play. This is, again, vascular disease causes issues elsewhere. Again, ischemia and pain, significant limits in activity. That's your intermittent claudication. When you go to a certain intensity, the calf pain comes back. Once you stop, the calf pain goes away. May be caused by a thrombus or an embolus. Signs and symptoms. First one, that intermittent claudication, that pain in the calves with walking. Paresthesias, numbness and tingling in the extremity. Okay, you ever sleep awkward and you wake up and your arm is numb or your foot's numb, depending on how you're sitting? That's what's happening. You're occluding, you're pinching off the blood supply of the nerves and they get paresthesias. Once you sit up, blood comes back, that numbness and tingling goes away. And ischemic ulcerations, why are they getting that? No blood supplied to the area. They're going to get ischemic changes. That's like what's going on with those bed sores with elderly. When they're in bed for a long period of time, they get bed sores. Where do they normally happen? Sacrum, pressure area, and heels. Because those are the areas that are right by the bed. There's not a lot of fat there usually, under back of your heel, so that bone is in contact with the mattress for a long period of time. You all do cap refill, right? And you push down, and the blood goes away, you release, it comes back. But if you keep it there for 5 days, you're going to start seeing some changes because you're not going to have any blood supply in your fingertip. That's where that comes in. So this is what it looks like. Again, unilateral for the most part because one vessel will be affected, maybe not both. But the 6 P's are what you got to know. It causes pain, pallor, pulselessness. Why pulselessness? You have an occlusion to the artery. So you all do your check of your extremity pulses, right? You do the femoral, popliteal, anterior tibialis, dorsalis pedis, right? You feel for all those pulses. So if I can feel the femoral, I can feel the popliteal, but I don't feel a dorsalis pedis, then I know the occlusion is somewhere in my lower leg. That's why you check pulses going down. Because if I don't feel a pulse in the foot, but I feel it in the knee, at least I know there's flow up to the knee, and then downstream, there's a block somewhere, and you'll get imaging for all that. Paresthesias, poikilothermia, and maybe paralysis. These can also be seen with severe venous insufficiency as well, but for the most part, these 6 Ps go with peripheral arterial disease. What don't you notice about these both pictures? What don't you see? Swelling. Because there's no blood even getting into the leg. So there's no blood, there's no swelling, because swelling means there's fluid there or blood there. And in these cases, there isn't. Hydrostatic pressure is not high in these patients because there is no blood. There's an occlusion there. So that's peripheral arterial disease. This is chronic venous insufficiency, also known as venous stasis. This is where you see that hyperpigmented brown skin in the lower extremities. That's venous stasis dermatitis. That brown, it's basically blood that gets trapped in the skin from being pushed out so much from hydrostatic pressure. Basically, valve incompetence. Remember, we have those one-way valves in our veins, and they prevent blood from falling back down into our legs. We want blood flow to go up against gravity back to the heart. When you have these veins and these valves being incompetent, blood will go up, but then as soon as you stop moving, the blood's going to fall back down due to gravity. Which is why I said with venous stasis or venous insufficiency, when you go to bed at night, gravity is gone, we're laying flat. Blood can start to move now, so the swelling goes away with venous insufficiency. When you wake up in the morning, your feet are normal size. But as you're walking around all day, gravity is keeping it down and your feet swell. But they go away at night. If you have edema in both legs and you go to bed at night and the swelling doesn't go away, probably heart failure, because in those cases, the heart failure is not going to change your swelling overnight. Common veins, superficial femoral vein is affected, anterior posterior tibials, and your perineal vein. So basically loss of wall tension, because all the blood's falling now, leads to stasis of blood and progressive edema. We're increasing the hydrostatic pressure, right? That blood is sitting in the veins more than it should, exerting a stronger hydrostatic pressure, pushing the fluid out, and that's why you get edema with venous insufficiency. So again, shiny, thin, atrophic skin, dark, pigmented skin, that's that venous stasis, dermatitis. Stasis ulcers, again, they get some poor wound healing, itching, dull pain with standing because the blood's pooling in the legs and it's trying to push out and it causes pain and maybe cause some itching, pruritus. And then obviously edema more so at the end of the day because you're upright and you're walking. So the swelling gets worse. If you have this and you want to get rid of it, just wear TED stockings all day. The compression stockings, and then they'll get rid of the swelling. They get stasis ulcers, very painful, usually on that medial malleolus. Again, can occur anywhere, but again, look at the medial malleolus. It's a very thin layer of skin and the bone is right there. Any places where you have a bony prominence without much support on the outside are at risk for ulcerations. Back of the heels, medial malleolus, sacrum ischiotubrosi is when you're laying down in the bed all the time. Those areas don't have a lot of cushioning, and when you compress them for a long period of time, ulcers can form. Irregular, uneven edges, so that's why you have this little, looks like that, and again, where it's located. And we are done with cardio, okay? So on Friday, we'll do reviews, we'll do case studies, and then your exam is on Wednesday, okay? Have a great rest of your week. I'll see you guys on Friday. Thank you.